everybody for joining us. This is a Lunchtime Lecture Series. Great, we're at about half of our participants, so you know what? I think we'll just go ahead and get started here. All right. Well, welcome everybody. As you may know, my name is Meredith Kwok. I am the Associate Director of Alumni and Constituent Relations for the program in Public Health. This is the UCI Public Health Lunchtime Lecture Series, and we're back with episode 7. The intention of this series is to inform and engage our community and public health efforts that are happening right here in our backyard by highlighting some of our faculty, all in an easy to digest manner over your lunch. This is, of course, a critical time for public health on a global and local level during the pandemic, but also on a campus level as we transition from a program to a school. So as you know, our time together is short. I am about to introduce our speaker this week who will present, and then we'll open up the conversation to Q&A using the Q&A function below, not the chat, the Q&A, and this will be recorded for future viewing purposes. So with us today is Dr. Sora Park Tanjasiri, a professor in the newly formed Department of Epidemiology and Biostatistics in the Future School of Population and Public Health here at UCI. She is also Associate Director of Cancer Health Disparities and Community Engagement at the Chao Family Comprehensive Cancer Center. Her research focuses on community health promotion to reduce cancer health disparities among diverse populations, particularly Asian Americans and Pacific Islanders. She has served as PI or co-PI on over 24 funded cancer-related studies, and her research has been published in peer-reviewed journals such as American Journal of Public Health, Journal of the American Medical Association, Health, Education, and Behavior, and Health Promotion Practice. Dr. Tanjasiri also serves as an advisor on numerous nonprofit organizations, including the Orange County Asian Pacific Islander Community Alliance, St. Joseph's Health System Community Partnership Fund, and the Orange County Women's Health Project. She received her BA in biochemistry from UC Berkeley, MPH in behavioral sciences, and a DRPH in community health sciences from UCLA School of Public Health. So another Bruin turned anteater. Last week, Dr. Lakon was one as well. So we're so lucky to have you with us, Dr. Tanjasiri. And with that, I turn it over to you.
Thank you, Meredith. And thank you to the program in Public Health and our new School of Population and Public Health for the opportunity to speak today. So I'm very excited to share with you kind of what we're learning about cancer health disparities in the time of COVID. I will be sharing with you things that we are learning really right now in the field and on the ground. None of these are necessarily all fully formed, but I think it's an opportunity to share with you, and hopefully we will be able to mitigate some of the negative effects in terms of cancer in the future. So with that, I'll start just by saying that first I want to talk about kind of what is a cancer health disparity. According to the National Cancer Institute, a cancer health disparity is a systematic difference in cancer cases, cancer deaths, or the related health complications and negative impacts that cancer can have. And these systematic differences happen among people in specific groups. They could be in the context of race, ethnicity, or in terms of disability, gender and sexual identity, income, education, and other characteristics. This is something I pulled off of the National Cancer Institute website, and you can see examples of this. For example, African American women are nearly twice as likely as white women to be diagnosed with a particularly aggressive form of breast cancer. Similarly, Asian Pacific Islanders and Asian Americans and Native Pacific Islanders are at higher risk of liver cancer compared to other groups. And there are many reasons for this. There's quite a bit of literature that shows that the reasons for these differences fall into many kind of buckets. For instance, it could be due to genetic and biological factors. For instance, we're finding an African American and their risk for triple negative. breast cancer, but it can also be due to social environment, so healthcare access, socioeconomic factors like income and education, exposure to chemical and physical um, uh, influences on cancer, and then behaviors like diet and physical activity. So in my role as Associate Director for the Cancer, Health Disparities, and Community Engagement for the Chao Family Comprehensive Cancer Center at UCI, I spent a lot of my time looking at data around differences in cancer incidence and mortality in Orange County. And you can see we do have, by ethnic and racial group, differences in these systematic differences in cancer health. For instance, breast cancer, as if you look at age-adjusted cancer mortality rates, white women have the highest rate of cancer mortality from breast cancer. But you can look across and see that Latinx populations have higher rates of cervical and breast and liver cancer and stomach. And for Asian Pacific Islanders, they have higher rates of liver and stomach cancer. And these are cancer deaths. What you may see in terms of colon cancer as similar death rates, I do like to point out that part of what cancer health disparities means is that groups are not benefiting equally from our ability to reduce death. So you can see in this graph, the gray line is the mortality from colon cancer among whites. And this gray line is clearly decreasing over time between 2001 to 2017. But if you look at the blue line for Latinx and the orange line for Asians and Pacific Islanders, it's not clear that those two groups are benefiting. So even though the death rates look similar between these three groups in terms of colon cancer, when you dive deeper, you can see trends over time. Latinx and Asian Pacific Islanders, those rates appear to be at best staying same, possibly slightly decreasing, but not nearly at the same rate as for white um, residents in Orange County. Now, when we think about what contributes to cancer mortality and those disparities, we're often concerned about who's diagnosed at an early stage versus a late stage. And we've looked at this data as well. And if you look at the characteristics of just later stage, we'll group up every group, so stages 2, 3, and 4 cancers compared to what we classically call early stage or stage 1. You can see for the 5 of the most common cancers that compared to non-Hispanic whites, all other ethnic racial groups have higher proportions that are diagnosed at later stage. And you can see this again compared for colon cancer, for instance. Our Black, Latinx, and our selected of our Asian American groups, including Chinese and Korean, have higher proportions that are diagnosed at later stage. You can also see that this is true by insurance status. So no matter what ethnic racial group you are in, if you have Medicaid insurance or uninsured, you have higher proportions. There are higher proportions of Medicaid and uninsured who are diagnosed at later stages. And again, what are those contributors? We often put them into different buckets. So contributors to later stage diagnosis can be due to individual factors such as low income, or fear of cancer, hence not going in for screenings, or perhaps low literacy and lack of understanding of cancer and the benefits of early detection. But the buckets can also be systems level. So lack of access, for instance, and that includes not just transportation to get to a screening site, but also the availability of screening sites, the affordability, and the acceptability of those screening sites to the community. It can also be about the quality of health insurance. So those who are uninsured or underinsured are often because they don't have access, they have the kind of jobs that don't have access to employer benefit health insurance. And there can be delays in diagnosis and treatment. So many of our ethnic racial groups can go in to screening, but at the time, but they'll still experience delays once they have a positive screening in terms of diagnosis and treatment initiation. And we're concerned about all of these when we think about reducing cancer health disparities. Okay, let me pivot for a moment and now talk about what we're seeing, of course, in COVID. So similar to cancer health disparities, we see COVID disparities. And in this case, we're talking about disparities, it's systematic disparities between groups because of race, ethnicity, etc., and specifically for COVID deaths. So data that's available from the UCLA Center for Health Policy Research, their COVID-19 dashboard, shows that in California, deaths are absolutely being experienced differently by different ethnic racial groups. The light bar shows the proportion of that group, the population in California, and the darker bars are their proportion of deaths to COVID-19. And you can see a higher proportion of Latinx and Blacks are dying compared to their proportions in the population. Now you can look across and see, well, that might not be as true for whites, Asians, and I'd like to specifically call out our Native Hawaiian and Pacific Islanders, or the NHPI, because there are other ways that you can look at these disparities. And another way is to look at the rate of death, rate of mortality per 100,000. And in this case, you can see that the death rates per 100,000 are highest for, again, Latinx and Blacks, but also Native Hawaiians and Pacific Islanders. And this is alarming because you wouldn't see this if you only looked at proportional deaths. You have to dive deeper. We're seeing a lot of this borne out when we talk to community members and try and understand what are they facing in terms of barriers to care and just in terms of survival and coping for COVID-19 in the community. We have conducted key informant interviews in Orange County with leaders of organizations and agencies. And what we're finding is, just the same kinds of challenges that are often attributed to delays in care in general. So lack of timely access to in-language information, lack of access to preventive services, particularly for cancer screenings, no cancer screenings really, because of the shutdown of many non-essential, health services between March and July. That included a lot of our cancer screenings for breast, cervical, colon, etc. A large fear of communities to even go to the clinics for preventive care, and the difficulty of doing telehealth in our communities, partly because of the lack of access to computers and microphones and cameras, etc., and the discomfort of using those kinds of technologies to really interact and communicate health messages. We're seeing our communities already experiencing late diagnoses and also associated anxiety, depression, and fear. Here's just an example of one of our key informants who shared with us generously what they found when they did an assessment within a primarily Latinx community. The proportion of their clients who were, for example, already have a chronic disease, 47%, 68% were housing insecure, 67% lost their jobs, and 51% could not or were not accessing unemployment benefits. 91% had not applied for any kinds of relief, even though they were eligible for regarding COVID-19, and 92% were not accessing cleaning supplies. And from another one of our key informants, this, I think, very telling quote, she said, community members should not have to find the resources by themselves. The lack of programs in communities is an issue, and this is all regarding COVID-19. So now let's put this two together. What are the challenges we're seeing in COVID-19, and what does it mean for cancer? So there has been emerging evidence about the shutdown in cancer screenings resulting in reduced volume, such that, so for example, this figure shows that the weekly cancer screening volume In 2020, so those are the numbers, week 0, 10, 20, 30, etc., compared to similar weeks in previous years for breast at the top, colon in the middle, and cervical cancer screenings. These data were pulled from 60 healthcare organizations representing over 300 hospitals in 28 states. And what they found is the number of cancer screenings completed in each week comparatively so that the number of missed cancer screenings is estimated to be for breast 285,000, colon 95,000, and cervical 40,000 missed cancer screenings. And these are exactly the missed screenings that can lead to later diagnosis and poorer outcomes. And this is across all ethnic racial groups. This is what's happening in the US. There have been other studies that have looked at what does this mean, right, in terms of the potential of late stage diagnosis. According to the IQVIA Institute, there have been over 22 million screening tests and over 80,000 positive cancer diagnoses that have been potentially delayed because of these delays in screenings or these lack of screenings. And then also, according to Dr. Ned Sharpless, who is the director of the National Cancer Institute, when they've modeled what the lack of screenings mean for potential excess deaths, they have found that there's potentially up to 10,000 excess deaths from breast and colorectal cancers alone in the United States that are estimated to have occurred because of our COVID-19 and our reduced access to cancer screenings. And I think a really important question to ask is who will be most impacted by these delays in screening and deaths? And we have every reason to believe that the same populations, ethnic racial groups, and low-income groups that were traditionally experiencing cancer health disparities will be the same groups who will be disproportionately affected by these delays due to COVID-19. So in just one of my last few slides, I want to remind everyone that the American Cancer Society still has recommendations on their website about what regular screenings should be obtained. So for example, these are in terms of cervical cancer, mammograms, and colorectal cancer screenings. And I'd like to share that the California Dialogue on Cancer, which is our California Cancer Plan group, is about to release a 2021-2025 strategic plan. And in there, they state that one goal is to increase the equitable access to cancer-related preventive, diagnostic, treatment, palliative, and end-of-life care for uninsured and underinsured populations, which are oftentimes our ethnic racial groups. So lastly, I want to say that here at the UCI Chao Family Comprehensive Cancer Center and in the School of Population and Public Health, we have a relatively new Office of Community Outreach and Engagement. The mission is to do exactly that, to eliminate cancer health disparities and promote health equity by partnering with individuals, communities, and institutions to reduce the burden in Orange County. I'm happy to share that we have a director, Ms. Savani Lee, and two health educators, Mr. Jonathan Garzon and Ms. V. Lay, who are part of this office, and they have worked tirelessly to develop partnerships and coalitions with organizations and entities across Orange County. Here's an example of some of those with a map on the left showing all the numerous partnerships that this office has currently, with, again, the goal of reaching out, understanding, educating, researching, and ultimately reducing the cancer health disparities in ethnic, racial, and our low-income populations. If any of this speaks to you in terms of your interest to support, I encourage you to check out the Cancer Center's annual Anti-Cancer Challenge. It is, you can find out more at anticancerchallenge.org. It has been historically in the past, the last 3 years, in person. This was some of the members of my team last year that went out to run, walk, and ride. But this year will be completely virtual. There is no charge to join, and I invite you to join in our anti-cancer challenge. And also to look up, if you're interested to learn more about our Office of Community Outreach and Engagement. And with that, I'll end and turn it back to you, Meredith. Thank you.
Thank you. Thank you so much. And it's always fascinating to hear about what is happening right in our community and then a way that we can get up and help tomorrow. And from my understanding, the challenge is happening as we speak. So we're able to have it over a longer period of time, culminating in the day in October. Is that right?
Yes, sorry I didn't mention that. That's right. There are activities going on right now, webinars, challenges, physical activities, for instance, and it'll all be culminating in October, early October. October, is it 5th? With our ultimate, kind of day of event to again celebrate our communities coming together to fight cancer. And I do also want to say that every dollar raised goes back to research here at UCI to understand and address and ultimately reduce the cancer burden among residents in Orange County. So it's not often you can say every dollar raised goes back exactly to that.
It's a fantastic fundraiser and important at this time that we take care of our own health and stay active and get outside. So there's a few questions here. First is, you touched upon this a little, but one of our guests is asking what you think the major cause of cancer mortality disparity is in Orange County and the United States. And you named a few, but do you think there's one that's stronger than others?
It's so hard, to name just one because these factors happen together. So it's not, for example, just that individuals are afraid of cancer diagnosis and won't go in to get screening, but oftentimes those populations are the same ones who have lack of access to information, right, about the benefits of screening. And they also have lack of access to affordable places to go to get screened. And so we talk about things as being very multi-level. It's a combination of individual, healthcare institutional, and even community and policy factors that work together to, kind of create these disparities. I will say that the United States has the dubious honor of being, a country with some of the largest disparities in health. And so I want to say that we are unique in the fact that there are these systematic differences in health and disease that break down by racial, ethnic, sexual identity and orientation, et cetera, those disparity groups. And so I don't think that's something that we can be very proud of, but it does make us unique because we are such the access to healthcare in this country is so fragmented.
Thank you. The next question is, would it be wise to adjust screening protocols to recommend earlier screening for these groups and people of color?
That's interesting. Yeah, I mean, what I think that question gets to is sort of more of a personalized prevention, right? And based on what we know about individual or group-based risks. And that's actually already happening to some degree as the research is becoming more clear about certain groups that are at higher risk. The recommendations are being nuanced. So you will see when you go, for example, to the American Cancer Society website, that oftentimes they talk about decision-making for screening being based on a shared process with your healthcare provider. So those of us who are lucky to have a healthcare provider should be talking to them about what are our personalized risk based on family history, based on our current behaviors. For example, if I'm a smoker, or if if I'm physically inactive, that might elevate my risk for certain cancers. And then come to an agreement about what should be the screening, and not only the screenings that I should do, but the frequency within which I should do them.
Thank you. And one more question. Another audience member is asking for a little more information on how these populations can seek screening when, as you mentioned, screening has become so limited in in-person health services. You named some of the organizations, but are these resources all available online, anywhere they can be directed?
That's a good question. So I would say that there is a lot of emerging information that is online. You can go to the Orange County COVID-19 website, and you can go, for example, to the American Cancer Society website. I think there might be a little bit of a disconnect, though, between what is recommended. So what is being recommended is a reopening of all cancer screenings, many of which can be done safely during COVID-19. For instance, with colorectal cancer, you could be sent a FIT test that you could do in the safety of your own home and mail it back to do a kind of a first step screening for if there's any concerns around colorectal cancer. All of these kinds of what I want to say, screenings, many of them are available and can be done safely during COVID-19. And also, the Centers for Disease Control and Prevention has issued guidelines to healthcare institutions about how to safely provide screening. So I had put it in my presentation and I ended up taking it out, but there is about 6 or 7 recommendations that the CDC is making for all healthcare institutions, clinics and hospitals, to ensure the safety of screenings. I mean, the bottom line is our hospitals have not closed, right? And so if there was ever a need for a screening or a diagnosis based on, for example, elevated risk, individuals should still be going in. But what we're talking about is for people with average risk, right? For whom these delays felt perhaps merited because we didn't want to potentially expose ourselves to COVID-19. So for people with average risk, I do want to assure you that from the American Cancer Society all the way down to our local clinics and hospitals, we're all trying to reopen our doors safely to ensure that we can conduct cancer screenings. So check with your provider or your clinic, give them a call and see whether they're offering those services. By the way, at the same time, as you're asking about that, please also ask for a flu vaccination, because we also want to ensure that everyone is becoming protected from what can oftentimes be a very rough flu season. And we want to reduce the demands on our healthcare because of complications from the flu. So call your doctor if you do not have access to a regular physician. The Orange County has a coalition of community health centers that provide care for underinsured and uninsured. And you can call your local, you can go to the website for the Orange County Coalition of Community Health Centers. Or just contact our Office of Community Outreach and Engagement. We'd also be happy to direct you as well.